So, welcome to the Kanski lecture series, and this is a retinal vascular disease part 8. And in this part, we are going to discuss about the ocular ischemic syndrome. Introduction. Ocular ischemic syndrome result from the chronic ocular hypoperfusion secondary to severe more than 90% ipsilateral atherosclerotic carotid stenosis. So whenever there is a carotid stenosis, you know that the blood is not getting enough supply to the ophthalmic artery and there is a hypoperfusion of the eye. This is a result in ocular ischemic syndrome. It typically affects older patients and may be associated with diabetes, hypertension, cardio, and cerebrovascular disease. And most of the time, it occurs in a case of an older patient. It may be associated with diabetes, hypertension, cardio, and cerebrovascular disease. The male to female ratio is 2:1. It's 2:1. 5-year mortality is around 40% most frequently from the cardiac disease, and the mortality is around 40%. OIS, ocular ischemic syndrome, along with the non-ischemic CRVO, is sometimes termed as venous traces retinopathy, but it may be prudent to avoid this term. Diagnosis. OIS is unilateral in 80%. The signs are variable and may be subtle, such that a condition is missed or misdiagnosed. So, OIS is unilateral and it is having 80% of the cases. The signs are variable and may be subtle, such that a condition is missed or misdiagnosed. Symptoms: there is a gradual loss of vision over weeks or months, although occasionally loss may be sudden or intermittent. Amaurosis fugax. So the vision, there is a gradual loss of vision over weeks or month, and there can be amaurosis fugax, or there is transient blurring of the vision. Ocular and the periocular pain may also be present. 40%. Patient may notice an unusually persistent after imaging or worsening of the vision with sudden exposure to bright light. Amaurosis fugax. So patient will notice that there are persistence of imaging and worsening of imaging with the exposure to bright light. The prognosis for vision is often very poor, though patients with better acuity at presentation are more likely to retain this. About 25% will deteriorate to light perception by the end of 1 year. Anterior segment. So, what are the signs of the anterior segment? There will be the diffuse episcleral injection and corneal edema, aqueous flare and few cells. So there will be aqueous flare and few cells, ischemic pseudoiritis, iris atrophy with mid dilated poorly reacting pupil. So there will be the mid dilated pupil, and the pupil will be poorly reacting because of the iris atrophy. Dubois iritis is common, so neovascularization of iris is common, developing in up to 90% and often progress to neovascular glaucoma. So whenever there is an NVI, there is a chance that there will be the progression to the neovascular glaucoma. The IOP may remain low due to poor ocular perfusion. Cataract in advanced cases. So fundus will show the venous dilatation and arteriolar narrowing, deep round and flame shape, and occasionally disc edema and cotton wool spot. So there will be the venous tortuosity. There will be the narrowing of the arteries. There will be the hemorrhage, flame shape hemorrhages, disc edema, and cotton wool spot. Proliferative retinopathy with NVDs and occasionally NVEs. Spontaneous arterial pulsation most pronounced near the optic disc is present in most cases and may easily be induced by exerting gentle pressure on the globe. Digital ophthalmodynamometer. So if there is a spontaneous arterial pulsation which is usually absent is present, then it is the case of an ocular ischemic syndrome. And it can also be present in most cases and may be easily induced by exerting a gentle pressure on the globe. Digital ophthalmodynamometry, which is also known as a digital ophthalmodynamometry. Macular edema can occur in diabetic patients. The retinopathy may be more severe ipsilateral to the carotid stenosis. Fluorescent angiography, delayed choroidal filling. So because the perfusion is poor, so there will be the delayed choroidal filling, and prolonged arteriovenous transient is the major feature. Non-perfusion vessel wall staining and retinal edema may also be evident. Carotid imaging may involve duplex ultrasonography, digital suppression angiography, and MRI or CT angiography. So there can be CT angiography, MR, and the DSA as well. So what will be the management? Management will be the anterior segment inflammation is treated with topical steroid and mydriatic as appropriate. So if there is an anterior segment inflammation, we can use topical steroid as well as mydriatic. Neovascular glaucoma is managed medically or surgically. Proliferative retinopathy can be treated with PRP along the outcome. Although the outcome is considerably less certain than in proliferative diabetic retinopathy, intravitreal anti-VEGF agent may be beneficial because the basically the cause is that there is a hypoperfusion. Then the PRP is have outcome is being uncertain. Macular edema may respond to intravitreal steroid or anti-VEGF agent or to a carotid surgery. So the main thing is you do the carotid surgery and you nip the eagle in the bud. And arterectomy or stenting may be performed to reduce the risk of stroke. It may be beneficial for proliferative retinopathy and neovascular glaucoma and may help to stabilize vision. Endarterectomy cannot be performed when there is a total obstruction, and in this situation, extracranial and intracranial arterial bypass surgery is sometimes carried out. It should be noted that an increase in ocular perfusion following surgery can sometimes be associated with rise in IOP. Surgery tend to be of a greater benefit when performed before the onset of a severe ocular ischemia. So, endarterectomy or stunting is basically you make the passage in the carotid artery and you bypass the stenosed area. So it is basically most beneficial in a case of a proliferative retinopathy and neovascular glaucoma. And when the endarterectomy cannot be performed when there is a total obstruction, and in this situation what we do, we perform the arterial bypass. We do the extracranial to intracranial arterial bypass, and it can sometimes lead to sudden increase in IOP. Investigation and management of the cardiovascular risk factor in conjunction with the appropriate medical specialist is essential. OIS is occasionally the only manifestation of the marked systemic vascular disease. Full investigation should be carried out broadly, similar to that of a retinal arterial occlusion. So this is you can see. So this is you can see that this is a picture of a ocular ischemic syndrome. A is showing venous dilation, arteriolar lining, a few scattered flame-shaped hemorrhages, and hard exudate and disc edema. So there is a disc edema, there is a dilatation of the vein, there is a arteriolar narrowing, there is a macular edema as well. And B is showing that there is a delayed choroidal filling and there is a delayed arterial and venous filling as well. So B and C, FA early phase show delayed choroidal filling and prolonged arteriovenous transient time. FA late phase showing disc and perivascular hyperfluorescence with spotty hyperfluorescence at the posterior pole due to leakage. Next is a hypertensive eye disease. So hypertensive eye disease occur due to the hypertension, and there is a retinopathy in a case of a hypertension is known as a hypertensive eye disease. So hypertension not only affect the retina but also it also affect the choroid. So when it affects the retina, it is known as retinopathy. Systemic arterial hypertension is common in addition to heart, kidneys and brains. The eyes are often affected by hypertension. Ocular effect can be observed in the retina, choroid and optic nerve. So basically such effect can also be observed by retina, choroid and optic nerve. The primary response of the retinal arterioles to systemic hypertension is vasoconstriction. So there is an arteriolar narrowing in a case of a hypertension eye disease, which is less marked in older individual because of the involutional sclerosis conferring increased rigidity. Arteriosclerosis refer to hardening and loss of elasticity of the small vessel wall, uh, manifested most obviously by the arteriovenous nipping at the crossing point. So what is happening that there is a arteries become atherosclerosed and there is a hardening of the arteries and there is a loss of elasticity of the small vessel, and which shows as an AV nipping crossing point. The presence of the signs makes it possible that hypertension has been present for many years even if the BP is currently controlled. Mild AV changes may be seen in the absence of the hypertension. In sustained hypertension, the inner blood retinal barrier is disturbed. disrupted increased vascular permeability, leading to the flamed shaped retinal hemorrhage and edema. So whenever there is a very strong hypertension, or hypertension is persistent for the very long time, it can lead to the blood retinal brain barrier disruption. It can cause increased vascular permeability, leading to the flame shaped hemorrhages. So there are four grades: 1, 2, 3, 4. The grade 1 is showing the mild generalized retinal arteriolar narrowing. Grade 2 is showing a focal arteriolar narrowing and arteriovenous nipping. A copper wiring opacified appearance of the arteriolar wall may be seen. So there will be the in a grade 1, all the arteries will have a generalized narrowing, but in case of a grade 2, there will be the focal narrowing of the arteries, and there will be the AV nipping. And there is a copper wiring can also be seen in a case of an which is basically the opacification of the arteriolar walls. Let's see figure 13.43. So this is a 13.43. A is showing us a generalized arteriolar narrowing. B is showing a focal arteriolar narrowing. So this is a focal arteriolar narrowing. This is showing AV nipping, atriovenous nipping, and C is showing us D is showing us a copper wiring. So you can see that it's like a copper wire has been in the retina. Next is that grade 3 and grade 4. So grade 3 consists of the, whenever there is a retinal hemorrhages, it is known as grade 3. Grade 3, grade 2 plus retinal hemorrhages, dot plot flame exudate, chronic retinal edema may result in the deposition of the hard exudate around the fovea as a macular star and cotton wool spots. So it can also grade 4 is severe grade 3 plus optic disc swelling, which is a marker of a malignant hypertension. So whenever there is a disc swelling, it is known as a grade 4. And sometimes the macula, there is a deposition of hard exudate around the fovea which form the macular star in a case of a diabetic retinopathy. So you can see that E is showing us a grade 3 retinopathy. So you can see there is a cotton wool spot, there is a macular star formation. And in the case of F is a grade 4 hypertensive retinopathy showing extensive cotton wool spots and slight disc swelling. So next is a marker of a preclinical systemic disease. So whenever there is a reduced retinal arteriolar caliber is an early prehypertensive sign, and if identified should prompt PP monitoring. Wider venular caliber is relatively specific for impaired glucose metabolism. So there is a narrowing of the arteries and there is a wide venular caliber, and it is showing us an impaired glucose metabolism. Low arteriolar caliber and a high venular caliber are both thought to be the marker of the preclinical cardiovascular disease. Increased venular tortuosity can be associated with chronic hypertension and prehypertension, so evidence of an arteriolar tortuosity is conflicting. Straightening of the arteries has been reported in some studies. Numerous other causes of the retinal vascular tortuosity have been described, notably conditions associated with high and low vascular flow. Choroidopathy. Hypertensive choroidopathy is rare but may occur as a result of an acute hypertensive crisis, accelerated hypertension in young adult. Cygrist streaks are flex arranged linearly along the choroidal vessels and are indicative of the fibrinoid necrosis associated with malignant hypertension. So whenever there is a choroidopathy that the choroid is being affected, it is known as hypertensive choroidopathy. It usually occurs as a result of an acute hypertensive crisis in a young adult. So cygrist streaks are basically flecks that are arranged along the choroidal vessels, and they represent a fibroid necrosis in the malignant hypertension. So let's see figure 13.45. This is a 4-4 is showing a vascular tortuosity. A is showing selective venous tortuosity. The arterioles are unaffected. B is showing mixed arteriolar and venous tortuosity. So this is showing the hypertensive choroidopathy. A is showing histology showing a fibrinoid necrosis. So this is a liquefied necrosis in a choroidal arterioles in a malignant hypertension. So this is a cygrist streak, which is basically the whitish fleck shape along the choroidal vessels, and it is basically showing us the fibroid necrosis. And this is an Ulshing spot, which is a whitish spots in the choroid. So next is an ulcering spots are focal choroidal infarct seen as a small black spots surrounded by yellow halo. So there is a black spots which is surrounded by yellow halo. It is known as ulcering spot. Exudative retinal detachment, sometimes bilateral, may occur in acute severe hypertension such as those associated with toxemia of the pregnancy. So ERD can also occur in the case of a hypertension retinopathy. So next is the sickle cell retinopathy. So sickle cell retinopathy occur in those having a disease sickle cell. So sickle hemoglobinopathy is basically there is a hemoglobin which is being effective, which is a normal part of our blood. Sickling hemoglobinopathies are caused by one or more abnormal hemoglobins that induce red blood cells to adopt an anomalous shape under condition of a stress physiological stress such as hypoxia and acidosis with resultant vascular occlusion. So whenever there is some kind of stress, it changes its shape and it causes in the sickle cell formation and causing an obstruction of the uh, uh, vascular system. Mutant hemoglobin variant S and C can be found in combination with the normal adult hemoglobin A or less commonly with other mutant hemoglobin variant. So there can be hemoglobin S, there can be hemoglobin C. Retinopathy can occur in sickle cell disease homozygous for the mutant hemoglobin S. So retinopathy can also occur in sickle cell disease, which is SS, in which both the hemoglobin are having a defective gene. So sickle cell disease. So there is an SC. Most likely to develop severe retinopathy. So the most severe retinopathy is first in the SC, then thalassemia, and then there is a sickle cell disease. But the most severe form of the disease is basically SS. But the most common ocular part that is being affected is basically SC. The most likely to develop severe retinopathy and sickle cell thalassemia disease. It is rare in patients with sickle cell traits SA found in 10% of African American unless there is other coexisting systemic disease such as diabetes or an inflammatory disorder. So it is also rare in a patient who are usually African in a case of having a trait SA. Carbonic anhydrase inhibitor should be avoided in these disorders as these can precipitate sickling and vascular occlusion. So that is why carbonic anhydrase are contraindicated in case of a sickle cell hemoglobinopathy. So what are the signs in the anterior segment? So the conjunctiva, there will be the dark red corkscrew or comma shaped vessels that are typically transient. So there will be the corkscrew vessels and it can be comma shaped. Iris patches of ischemic atrophy often extending from pupillary edge to collarate and occasionally rubeosis. So in the iris, it can have a patchy iris atrophy which can extending from the pupillary edge to collarate. Hyphema may be spontaneous or follow minor trauma. Careful IOP monitor control avoiding carbonic anhydrase inhibitor is critical to reduce the risk of RVO in the presence of a hyphema. So whenever there is a trauma and there is a hyphema, then in a case of a sickle cell disease, we control the IOP as soon as possible because it is very important. It can lead to the permanent optic neuropathy. Next is a non-proliferative retinopathy, and then there is a proliferative retinopathy. So non-proliferative retinopathy, there will be the venous changes which will uh, like a case of a retinopathy, there will be the venous changes. Toxicity is very common and is thought to be due to peripheral arteriovenous shunting. RVO is uncommon. Thaw is a risk with raised IOP. Arteriolar changes occlusion can involve a branch, central, or macular vessel, and if seen acutely, may benefit from a year such as 100% oxygen and exchange transfusion. Silver veiling of the arterioles in a peripheral retina signifies previously occluded vessel. Corkscrewing of the peripheral vessels may be seen. So arterial changes can be that there can be certain BRAO, CRAO, and other cases can be occur and which can be treated with 100% oxygen in a first 24 hours. Optic disc sign of sickling is the dark red blot on the disc surface due to the small vessel occlusion. So then there is a Salmon patches, which is basically orange red mid peripheral, a superficial intraretinal hemorrhage. So these are intraretinal hemorrhage, which are usually superficial, and they are orange red that may break through through to become preretinal and subretinal as well. So it can become preretinal and subretinal as well. The initiating event is thought to be vascular occlusion. Salmon patches resolve to leave schisis cavities containing refractile deposits, black sunburst, when the RP is sufficiently stimulated or a combination lesion. So, whenever the salmon patches resolve, they leave a schisis cavity, which are basically a refractile deposit and black type. So, let's see figure 13.47. So this is a several sickle red cells and one nucleated red cells in the peripheral smear of a patient with the homozygous HPSS. So this is a sickling hemoglobinopathy. And 13.47 is showing us a non-proliferative sickle retinopathy. AF is showing macular ischemia. So there is a macular ischemia. So this is an RPE hyperplasia, black sunburst, and pre-retinal hemorrhage, Salmon patch. So this is a Salmon patch, and this is a black sunburst. Black sunbursts are basically the patches of a peripheral RPE hyperplasia. So RPE become hyperplased and means that it proliferates, and chorioretinal atrophy that evolves from some salmon patches. The extent and morphology of pigmentation is variable, but an outer pale band is generally present. Macular retinal depression sign: an oval depression in the temporal macular retina due to retinal thinning following arteriolar occlusion with irregularity of the light reflex. Vascular anomalies such as microaneurysm and epiretinal membrane may occur. So there is a macular depression sign. So there will be the depression in the temporal macular retina. So this is macula area, this is all macular area. So in the temporal side there is some depression, which is basically due to retinal thinning following an arterial occlusion, and there will be the irregularity of the light reflex as well. Peripheral areas of whitening or darkening and angioid streaks are common. So next is a sickle cell proliferative retinopathy. So diagnosis: the development of the proliferative retinopathy is usually insidious with no symptoms unless vitreous hemorrhage or retinal detachment occur. So there are stages, basically there are 5 stages of the proliferative retinopathy. The diagnosis of the proliferative retinopathy is usually insidious with no symptoms unless vitreous hemorrhage or retinal detachment occurs. Stage 1: peripheral arteriolar occlusion. So first stage will be, there will be the arteriolar occlusion. Second stage is basically there will be the peripheral arteriovenous anastomosis proximal to the non-perfused area. So there will be the AV anastomosis. Stage 3 will be the C-fan neovascularization develop at the edge of the perfused retina, usually with the single supplying arteriole and a single draining venule. So there is a single supplying arteriole and a single draining venule, and there will be the C-fan like neovascularization. This vascularization may occur. Stage 4 is the vitreous hemorrhage from the neovascularization tip. Avoid the use of a carbonic anhydrase inhibitor with the patient with sickle cell anemia, as these drugs can cause sickling and vascular occlusion. Stage 5 is a rhegmatogenous retinal detachment caused by a retinal break associated with extensive fibrovascular proliferation. Tractional detachment may also occur. So you can see this is a proliferative retinopathy, sickle retinopathy. A is showing us a peripheral arteriovenous anastomosis. So there is an arterial occlusion here, and there is an anastomosis going on here. P is showing us a C-fan neovascularization. So this is a C-fan neovascularization. C is showing extensive fibrovascular proliferation. D is showing us a peripheral retinal detachment. Now E is showing FFA is showing filling of the new vessels and extensive so this area is basically non-perfused area, and there is an extensive filling of the new vessels. And FA late phase showing a leakage from the new vessels. So stage 1 is there will be the arterial occlusion, stage 2 will be there will be the arteriovenous anastomosis, stage 3 will be the C-fan neovascularization, stage 4 will be vitreous hemorrhage, and stage 5 will be rhegmatogenous retinal detachment. So there are in sickle cell both RRD and TRD can occur. FA in stage 3 show filling of the C-fan and peripheral capillary non-perfusion followed by the leakage from new vessel. Wide field imaging is specially suited to evaluation of this condition. Treatment. Observation: if vitreous hemorrhage has not occurred, particularly in middle age and older people, many neovascular complexes involute spontaneously as a result of an autoinfarction or fibrotic strangulation, subsequently appearing as a grayish fibrovascular lesion. So, if there is no vitreous hemorrhage, one can just observe because such neovascularization tend to resolve. Laser or cryotherapy ablation of the peripheral non-perfused retina is probably the optimal approach. Through ablation of the neovascularization may also be used. So you can also ablate the neovascularization as well. It is slightly different from the proliferative retinopathy of the diabetes. Ablation of the feeder vessel is now rarely performed due to high incidence of the subsequent choroidal neovascularization. Vitreoretinal surgery may be required for directional retinal detachment and persistent vitreous hemorrhage. Caution is required as anterior segment ischemia, potentially severe, is very common following scleral explant application. So you tend to perform BPV because a scleral explant is associated with anterior segment ischemia. Next is a thalassemia retinopathy. Thalassemia is a common genetic disorder in which mutation gives rise to an abnormal hemoglobin with the consequent failure of a normal blood cell maturation. So the RBC will not get matured. So ocular involvement occur in a patient with thalassemia major and thalassemia intermedia. So it can occur in thalassemia major and thalassemia intermedia. Changes are caused by the disease itself as treatment with the blood transfusion and iron chelating agents such as ferroxamine. So whenever the thalassemia is usually being treated by the blood transfusions and they are like desferrixamine is being given to reduce the iron level. So these treatment can also cause disease as well. A major mechanism is tissue deposition of the iron, which is siderosis from rising of the abnormal red cells. The ocular feature predominantly affect the posterior segment and are non-proliferative, though vitreous hemorrhage has been reported. So basically, it involves posterior segment, and the changes are usually non-proliferated, but sometimes vitreous hemorrhage has been reported. Visual dysfunction is rarely severe. Manifestation include cataract, a smooth featureless iris, vascular tortuosity, angioid streak, optic neuropathy, and pigmentary retinal mottling, including pattern dystrophy like macular changes. So there can be like cataract formation, there can be featureless iris, there can be vascular tortuosity, angioid streaks, optic neuropathy, and pigmentary mottling. The fundus appearance may resemble that of a pseudoxanthoma elasticum. So that's it for the part 8. See you in the next lecture.